Welcome, everyone. Sorry for the very slight delay. My name is Barbara Cochran. I'm the Associate Director of the Northwest Geriatrics Enhancement Workforce Enhancement Center, Northwest GWEC. And this is the last lecture of our geriatric healthcare series for winter term. We will be starting up again in spring, March 27th, with our Alzheimer's disease and related dementia series, a total of 10 lectures. For today, I'm just going to remind you that you should have filled out a profile form, you should have an evaluation form, and you should have a handout of the lecture slides, all of those from your site coordinators. In addition, if you would like continuing education contact hours for this series, your site coordinator has the information for you to register online and get continuing education credits. If you're not interested in continuing education credits but would like to view this lecture again or know of people who would like access to it, it will be posted on our nwgwec.org website within a couple of days of this live presentation. It's available for free, and it's amongst over 80 other lectures on geriatric healthcare. So today I am pleased to introduce Dr. Alan Chen, who grew up in Hawaii and Dr. Chen, who has special expertise in treating older patients with cardiovascular disease. He earned a bachelor's degree from Harborview College, am I pronouncing that right? And then attended the University of Michigan in Ann Arbor, where he earned an MA and a PhD in psychology. His dissertation research focused on the influence of age and gender on patient-physician interaction before he entered medical school to obtain his MD, so an incredibly vast background. He came to the UW in 1999 for an internship and residency in internal medicine, and then also completed fellowships in gerontology and geriatric medicine and cardiology here. He's board certified in cardiovascular disease. He's been a popular speaker in this lecture series, and today he's going to be talking about the management of atrial fibrillation, a focus on anticoagulation. So welcome, Dr. Chen.
Thank you. It's a pleasure to be here. For those of you who have the PowerPoints already printed out, there are a few changes way at the end. No new content, just reorganized for clarity. And we'll get started. I have no disclosures. I have three objectives. I'd like you to understand the basics of the management of atrial fibrillation and then learn how to effectively reduce the risk for older adults who have atrial fibrillation, and more specifically to understand the current options for stroke risk reduction. We'll start with a case. This is an 83-year-old woman with a history of hypertension, diabetes, and chronic renal insufficiency, as well as a prior GI bleed, who presents with mild palpitations and is noted to be in atrial fibrillation. Here's her electrocardiogram. You'll note that the rhythm is irregularly irregular, a little bit tachycardic, probably in the hundreds, in the low 100s, and without discernible P waves, consistent with atrial fibrillation. She undergoes a transthoracic echocardiogram as part of her workup to evaluate for structural heart disease, and it shows normal left ventricular size and systolic function. There are some mild age-related calcific changes in her aortic valve and mitral valve apparatus, but otherwise normal valve function. Her TSH is normal, excluding thyroid dysfunction as an etiology of her atrial fibrillation, and she has otherwise been well. How can you approach reducing her risk of adverse events, or how should she be managed? In terms of the management, we're going to go over three areas: rate versus rhythm control, strict versus lenient rate control for those for whom a rate control strategy is selected, and stroke risk reduction. So what is atrial fibrillation? Atrial fibrillation is an extremely common arrhythmia. And its substrate is abnormal atrial myocardium. So what is thought to happen is that there are hundreds of micro-reentrant or abnormal electrical pathway circuits firing chaotically in the atria. Some of those signals are let through the AV node and cause ventricular depolarization and that irregular rhythm. There are a whole host of predisposing factors. I've underlined some of the most common, which include cardiomyopathies, coronary artery disease, hypertension, being post-op, and having valve disease. As you can see, there are a lot of other ones listed as well. As the most common sustained arrhythmia, it affects about 10% of those who are 80 years old. At age 40, it's estimated that a person has a lifetime risk, so a future risk of about 25% of the development of atrial fibrillation. Atrial fibrillation is extremely interesting in that some patients are completely asymptomatic, have no idea that they're in atrial fibrillation, and other people know the moment they enter an episode of atrial fibrillation, they're highly symptomatic and it can be disabling. Symptoms may range from simple palpitations to mild or severe dyspnea, fatigue, decreased exercise tolerance, feelings of anxiety. And patients may develop the syndrome of heart failure just from having atrial fibrillation initiate alone. As you're probably aware, atrial fibrillation has a tight relationship with age in that increasing age is a marked risk factor for the development of atrial fibrillation. You can see the prevalence increases dramatically with increasing age. And this is, of course, important because our population is aging as well. A few sometimes underappreciated points about older patients with atrial fibrillation, other than their high incidence and prevalence, is that they have higher thromboembolic and bleeding risks. Their atrial fibrillation is less often paroxysmal and more often permanent. They often have atypical symptoms and complaints when they have atrial fibrillation. It tends to be underdiagnosed versus younger patients, in part because older patients tend to have more comorbidities and other problems that their symptoms may be attributable to or attributed to in error. Older patients with atrial fibrillation are more often frail or fragile with multiple cardiac and non-cardiac comorbidities. They tend to be less sensitive to the sympathetic effects on their ventricular response rates when they're in atrial fibrillation. That's another way of saying they sometimes don't need rate controlling agents or are auto rate controlled. And they tend to be more sensitive to the pro-arrhythmic effects of drugs which are designed to suppress arrhythmias. So antiarrhythmic drugs have a narrower therapeutic window or are in essence a little more risky to prescribe in older patients. So let's turn to the management. One of the first things a provider has to do when approaching a patient with atrial fibrillation is decide on whether to pursue a rate control versus a rhythm control strategy. A rate control strategy means giving medications when necessary to control rapid ventricular rates and providing anticoagulation if appropriate for stroke risk reduction, or pursuing a rhythm control strategy, which means trying to get a patient back into sinus rhythm and maintain them in sinus rhythm, and that can involve a combination of antiarrhythmic medications, electrical or chemical cardioversion, as well as anticoagulation. Multiple trials have not shown a mortality benefit to a rhythm control strategy. So for patients who tolerate their atrial fibrillation when rate controlled, that is a reasonable thing to pursue. Some patients are highly symptomatic, however, and will require a rhythm control strategy. And again, that rhythm control strategy may include antiarrhythmic drugs, cardioversion, and even ablation therapy. What is ablation therapy? I'm not going to go into it in detail, but ablations are performed by subspecialists, electrophysiologists who have advanced training in rhythm disturbances. It tends to be a relatively prolonged procedure, does have some paraprocedural risks, and ablation for atrial fibrillation is unfortunately not 100% effective. Sometimes patients require repeat efforts at ablation, and older patients tend to be at a little bit higher risk for those complications. It can be considered first-line therapy for some patients who poorly tolerate their atrial fibrillation, aren't candidates for antiarrhythmic therapy, or who fail antiarrhythmic therapy, and who are highly symptomatic with their atrial fibrillation. But it is usually reserved for folks who fail these other therapies. So for a patient who isn't going to pursue a rhythm control strategy, but rather a rate control strategy, which is going to be the majority of patients, we'll talk a bit about both the medicines used to control ventricular rapid ventricular rates, and as well what heart rate goals should be pursued. The three main categories of medications, all of which are AV nodal blockers, include beta blockers, some of which are listed there, calcium channel blockers, diltiazem and verapamil, not amlodipine or felodipine, which don't affect the ventricular rate, and digoxin. Beta blockers are very common, are used extensively in other cardiac conditions, including systolic heart failure in particular, and in patients who have angina or prior myocardial infarction. They have potential for adverse effects, including worsening of reactive airways disease, and potential contributor to depression. Calcium channel blockers also may have negative effects such as lower extremity edema and constipation. And then digoxin also has a narrow therapeutic window in that adverse effects can ensue in patients who have abnormal renal function, who are small, and in women. Digoxin tends not to be as effective as a sole agent for rate control, particularly with exercise. However, some patients, particularly older patients who have some disease in their conduction system, may require lower doses of medications to control their heart rates, as they may not go very rapidly to begin with. So there's been some controversy in the past about how strict rate control should be. In the past, and in some trials, patients have had goal heart rates at rest of less than 80 beats per minute, and then as well trying to keep them under 110 beats per minute with mild exercise. That's been evaluated in a few trials, resulting in recommendations from the American College of Cardiology and American Heart Association that a more lenient rate control strategy is reasonable. So from the guidelines, it's noted that a heart rate control strategy of arresting heart rate less than 80 is reasonable for the symptomatic management of atrial fibrillation, with perhaps not the highest level of evidence, but a level of evidence B. And this is a 2A recommendation, meaning it's, again, it's a reasonable thing to do. A 2B recommendation means a little bit less strong of a recommendation, but a lenient rate control strategy for arresting heart rate just less than 110 may be reasonable as long as patients remain asymptomatic and LV systolic function, so their ejection fraction, is preserved. Patients with a low ejection fraction tend not to do as well when their heart rates are very fast, and there is an entity called tachycardia-mediated cardiomyopathy. So sometimes if patients' heart rates are fast because of atrial fibrillation or another tachyarrhythmia, their LV can begin to fail. So we wouldn't want to treat somebody with a lenient rate control strategy if their LV systolic function was impaired. Okay, so we've talked about rate versus rhythm control, and then how to approach rate control when that is decided on as a strategy with regard to how strictly to control the rate. And now I want to turn to a discussion of how we can decrease stroke risk. As you guys know, the incidence of stroke increases with age, both in patients with atrial fibrillation as well as those without atrial fibrillation. And you can see that here. that the prevalence of stroke increases in both men and women as age increases. The percentage of strokes that are attributable to atrial fibrillation increases steeply from about 1.5% in the 50 to 59 year age group to almost 25% in those who are 80 to 89. And nearly 50% of AFib-related strokes occur in patients over 75. Other strong risk factors include prior stroke or TIA, diabetes, hypertension, and heart failure. AFib increases the risk of stroke more than any other cardiac condition. So looking at patients in the light gray colors who have high blood pressure, coronary disease, heart failure, or atrial fibrillation. So patients without high blood pressure, without atrial fibrillation have their stroke rate increased greatly by the presence of atrial fibrillation, and having AFib alone increases stroke risk significantly. Anticoagulation has been shown repeatedly to markedly decrease the risk of stroke, however, and these are 4 large atrial fibrillation trials comparing placebo in blue to warfarin in red, showing marked risk reductions in the incidence of stroke. I'm sure you are familiar with or have heard about the CHADS-2 and the CHADS-2-VASC risk scores for stratifying patients' stroke risk in those with atrial fibrillation. The CHADS-2-VASC score is has been supplanted by the CHADS-2-VASC score, which includes 1 point for a history of heart failure, 1 for hypertension, 2 for age over 75, 1 for diabetes, 2 for prior stroke or TIA or prior thromboembolism, 1 for vascular disease, 1 point for age 65 to 74, 1 point for female sex. So the maximum score on a CHADS-2-VASC would be 9. And then here on the right, you can see the corresponding stroke rates for those with CHADS-VASC scores as they go up. You can see that the stroke rate increases significantly. And while stroke rate increases with advancing age, there have been multiple studies that show that anticoagulation is in general underutilized in the elderly. Estimates are that only 30 to 50% of older patients without a contraindication to anticoagulation are actually receiving it. In one survey of atrial fibrillation patients, about 44% of patients with AFib 65 to 74 and 11% over age of 75 were treated. This was in an era where warfarin was the only anticoagulant used. Among patients who were not anticoagulated in another series, a contraindication was present in only 17%. And in another chart review of Medicare patients, warfarin was prescribed in only about half of patients with AFib and a prior stroke, so these are among the highest risk patients. And ideal candidates for anticoagulation with AFib with both an increased risk of stroke and a low risk of bleeding, in that population only about 62% were discharged from the hospital on warfarin. Another interesting study was performed with short write-ups of patients describing their risk factors for both stroke with atrial fibrillation. And what the investigators did was they gave these patient descriptions to physicians and surveyed them about whether they would start anticoagulation or not. And they changed the patient descriptors age, and when all they changed was the age, if they listed, you can see if they listed the age as less than 70, the percentage of providers who recommended anticoagulation is listed here, versus if they if they said that the patient was over 70, they listed their age as over 70, the percent that recommended anticoagulation went down, even though the patient's risks for stroke actually went up. Multiple reasons are given to withhold anticoagulation, including concern for bleeding, falls, age and life expectancy are actually given as reasons by providers for not prescribing anticoagulation. Cognitive impairment, alcoholism, and then concerns about compliance. And I don't mean to imply that these are not important concerns, but we should investigate how important these concerns are in the face of significant stroke risk. So here we see that in 5 major trials of atrial fibrillation, what the bleeding rate, the rate of major hemorrhage was, only about 1.2% per year in patients with a mean age of 70. That increased if patients have a history of peptic ulcer disease or a history of NSAID use, as you can see. What these lines list are risks of GI bleed in anticoagulated patients. So with a history of GI bleed, the risk is about 1% per year. NSAID use increases the risk of bleeding to about 4.5. However, if a PPI is prescribed with the NSAID, that reduces the risk to just over 2%. So also related GI bleeding risks, recurrences have been reduced due to the detection and treatment of H. pylori. And in many series, treated patients are found to be at no greater risk of rebleeding than those who have never initially bled. NSAID use does, however, confer ongoing GI bleeding risk, whereas, however, as noted, PPI use, misoprostol, can reduce the risk of a future GI bleed in those who must be on NSAID therapy. What about the patient who has fallen? Falls provide a dramatic demonstration for the risks of anticoagulation, and many older patients will report knowing someone who fell while on anticoagulation, and it also disproportionately affects providers' assessment for their patients' risks for a future bleed. Patients who fall, interestingly, tend to be those who are older with more comorbidities who are actually at increased risk of stroke. In patients who have fallen, it's been actually shown that warfarin therapy attenuates their risk of stroke more so than increases their risk of bleeding from falling. An important study using a Markov decision model technique found that regardless of age or baseline risk of stroke, the risk of falling was not an important factor for determining the optimal antithrombotic therapy, whether that was aspirin, warfarin, or no therapy. In fact, this model estimated that the risk of subdural hematoma from falling in patients with AFib with an average risk for stroke would have to fall about 300 times in a year for the risk of anticoagulation to outweigh the benefits. These are patients who are at significantly increased risk of stroke, and those who have a low CHA2DS2-VASc score and a relatively lower risk of thromboembolism. In those patients who have a great risk of falling, it may be reasonable to use falls as a reason to potentially withhold anticoagulation. Interestingly, as I've been implying, physicians underestimate stroke prevention by as much as 22% with anticoagulation, and they tend to overestimate bleeding risk by as much as 670% when surveyed. When AFib patients themselves, who are age 70 to 85, are educated on the risks and benefits of anticoagulation, about 61% choose warfarin. And about 47% of those not on warfarin say they would have chosen it if they had been given that as an option. An interview study of physicians and patients who are at high risk of stroke found that the minimum of strokes prevented, 100 patients over 2 years, to justify warfarin was lower for patients than for physicians. So patients, perhaps not surprisingly, seem to feel that that they would rather forego or rather be protected from stroke at a lower threshold than for physicians. And then the maximum number of bleeds acceptable for patients was higher than for physicians. So patients seem to be willing to take that greater risk of bleeding to reduce their risk of stroke. What tools do we have to potentially estimate the risk of bleeding that may lead us towards or rather away from prescribing anticoagulation? Well, there have been a number of efforts and risk scoring methods developed to try to help estimate the risk. 3 of these include the Atrial score, the Has Blood score, and the hemorrhages score. You can see the number of different factors that have been used in these risk scores in atria: anemia, renal disease, age, any prior hemorrhage, and hypertension. The Has Blood score, which is probably the most commonly used, evaluates some of those same things, but adds labile INR, specific drug use, which are listed, and alcohol use. And then the hemorrhages score, a little bit more cumbersome because there are more factors, adds hepatic disease, malignancy, reduced platelet number or platelet function, rebleeds, genetic factors, etc. How effective are these? So here the Has Blood score, again, probably the leading score is shown here, showing with an increasing preponderance of these bleeding risk factors, the estimated rate of bleeding per 100 patient years increases. This is a similar table for the hemorrhages score. Increasing number of those risk factors increases the bleeds per 100 years. So how should we best approach patients? We'll have a multiple choice question here that you can answer for yourselves. In order to balance stroke and bleeding risk, you should A, calculate the CHA2DS2-VASc score and the Has Blood risk score, and if the risk of stroke is greater than the bleeding risk, you should prescribe anticoagulation. But if the stroke risk is less than the bleeding risk, you shouldn't prescribe anticoagulation. Or B, calculate the CHA2DS2-VASc score and the hemorrhages risk score and make the same assessment. Or C, calculate the CHA2DS2-VASc score, and if it's greater than or equal to 2, for example, prescribe anticoagulation, but if there's a history of bleeding, lower the INR goal. Or D, calculate the CHA2DS2-VASc score, and if it's greater than or equal to 2, and the patient has a history of bleeding, then use aspirin and Plavix. So let's go through these. We'll tackle C first. While it is tempting to reduce an INR goal in somebody who has bled, the data actually show that INR goals that are less than between 2 to 3, and actually we tend to have a target of 2.5 in those patients, is not effective, and in most cases should not be used as a target. And then for D, aspirin and Plavix, while it does attenuate stroke risk, it doesn't reduce it as well as warfarin, and there's probably about the same amount of bleeding risk. So that's not generally a good strategy. And I'm also going to talk about other anticoagulation medications that may be useful in patients, in some patients. And then for A and B, it is tempting to say, well, I want to try to balance stroke risk and bleeding risk. So I have a stroke risk score and I have a bleeding risk score, so I'll just compare them, and whichever one whichever one ends up higher, I'm going to choose. Unfortunately, the bleeding risk scores have generally poor predictive accuracy. And so I've taken a couple statements directly from the AFib guidelines for the American Heart Association and the American College of Cardiology, which states that although these scores may be helpful in defining patients at elevated bleeding risk, their clinical utility is insufficient for use as evidence for the recommendations in this guideline. I'll note that has-bled seems to perform better than atria or hemorrhages at discriminating risk, and a risk score of greater than or equal to 3 indicates potentially the patient who has high risk for bleeding and may require closer observation of the patient for adverse risk, closer monitoring of INRs, or differential dose selections of oral anticoagulants or potentially aspirin. So they do not recommend comparing the risk scores and just deciding based on which one gives you a higher number. And that's important also because some patients will have a very strong desire to avoid stroke and may be more willing to put up with the potential increased risk for bleeding. And other patients may feel exactly the opposite way. I've certainly had patients who fall into both camps. With regard to anticoagulation, warfarin has been around for years and years, as you know, is a tried and true method, requires monitoring, requires some dietary adjustments or adherences, and may not be practical for some patients. Other patients may have very labile INRs despite doing everything they can to adhere to the dietary guidelines. There are a number of drug-drug interactions as well, particularly with antibiotics, that can alter INR levels. And we know that while warfarin is effective, it's really effective when it's therapeutic a good deal of the time, and that is a challenge for some patients. So acknowledging this, many companies have developed what we've called novel or direct or target-specific oral anticoagulants, and because of that, there are these acronyms which I've listed. And so I wanted to discuss some of these. So the 4 that are on the market currently are dabigatran, a direct thrombin inhibitor, rivaroxaban, apixaban, and edoxaban, all of which are factor Xa inhibitors. Dabigatran was evaluated in the Rely and Recover trial, one of which was an AFib trial, the other an acute venous thromboembolism trial. It's dosed twice a day, 150 milligrams. If a patient has renal impairment, as you can see here with a creatinine clearance between 15 and 30 mils per minute, the dose is adjusted to 75 twice daily. It should be avoided. It does have some GI side effects that are associated, which sometimes has caused patients to want to stop. Rivaroxaban, the first Xa inhibitor, was evaluated in both Rocket AF and in 2 acute PE or DVT trials. It's dosed once a day, 20 milligrams with the evening meal, and has a dose adjustment also for creatinine clearance. It is recommended to avoid its use in patients with Child-Pugh cirrhosis class B or C. Aristotle and Amplify were 2 trials utilizing apixaban. The dose for atrial fibrillation is 5 milligrams twice daily, with a dose adjustment if a patient has at least 2 of the following: age greater than 80, weight less than 60 kilos, serum creatinine over 1.5. For hepatic impairment, for mild impairment, no dose change is recommended. For moderate impairment, again, it's unclear, but it's recommended to avoid its use in severe hepatic impairment. Edoxaban is the most recent 10A agent. It was evaluated in Engage AF for atrial fibrillation. And if creatinine clearance is essentially normal, the dose is 60 milligrams per day. It has a creatinine clearance dose adjustment that's listed as well and should be avoided in cirrhosis class, Child's Q class B and C. In comparing the novel anticoagulants with warfarin, they tend to do very well in terms of stroke risk reduction. A few of the trials have shown a little bit more stroke risk reduction than warfarin, but in general they're considered equivalent with regard to stroke risk reduction. But they tend to have less in the way of intracranial bleeding, gastrointestinal bleeding, intracranial hemorrhage and mortality, although a little bit more in terms of GI bleeding than warfarin. They have a number of benefits, one of which is they don't need to be monitored. A flip side of the benefit of them not needing to be monitored is that they can't be monitored. So it's sort of a mixed blessing there. As well, only one of the agents, dabigatran, has what's called an antidote. So as you know, with warfarin, you can administer vitamin K for slightly sort of subacute lowering of the INR, or vitamin K for immediate reversal. With these agents, other than dabigatran, you just have to wait for the medication effect to clear, and then obviously you can transfuse if there's bleeding. The fixed doses are an advantage, and so many patients will prefer that. Unfortunately, because of many of our older patients have renal dysfunction, and particularly if their renal function is changing, that can make figuring out which dose to use or which agents the patient is eligible for more difficult. There tend to be fewer drug-drug interactions with these novel anticoagulants than with warfarin, which also can be an advantage. Adherence, of course, is important in both these novel anticoagulants and with warfarin. Because of warfarin's long half-life, missing a dose here or there tends not to result in as long, potentially as long a period of unanticoagulation as with the shorter acting anticoagulants. Also, some of the novel anticoagulants, particularly apixaban, is dosed twice a day, and so if compliance is a problem, then that may not be the best choice. There are contraindications to the novel anticoagulants, and those include patients with prosthetic heart valves, for which it is contraindicated. In pregnancy, low molecular weight heparin is preferred, particularly in the vulnerable period. We mentioned renal impairment, although apixaban appears to be the least renally dependent. Patients with antiphospholipid antibody syndrome should not be on a novel anticoagulant. And then again, patients for whom multiple daily doses, you'd want to avoid prescribing one of the novel anticoagulants that needs to be dosed multiple times. What about patients who are ineligible for anticoagulation? And those may include patients with a prior intracranial hemorrhage or a history of severe GI bleeding, which cannot be remediated via treatment of ulcer disease, for example. There are some mechanical approaches to the reduction of stroke risk. We know that over 80% of left atrial thrombi occur in what's called the left atrial appendage, which is a small pouch that extends off of the left atrium. So there have been a couple of techniques developed, one of which is the so-called Watchman device, which is a kind of a plug that sits in the left atrial appendage and excludes it. There is also something called the lariat device, which is kind of a lasso that's placed at the base of the left atrial appendage. Trying to find my pointer here. at the base of the left atrial appendage, essentially knotting it up and excluding it, and these, as well as if a patient is having cardiac surgery, open heart surgery, then sometimes they will resect the left atrial appendage. How these techniques will ultimately play out in terms of where and how often they're going to be used for stroke risk reduction isn't clear. The European AFib guidelines give a weak recommendation for those with contraindications to oral anticoagulation. The FDA has approved it for those who are eligible for oral anticoagulation, but who have other indications for non-pharmacologic therapy, so their lifestyle with high-risk sports or other activities that are more likely to be associated with bleeding, or those who have labile high-NARs. The ACC-AHA guidelines give a weak recommendation for left atrial appendage excision at the time of cardiac surgery, but gave no recommendation on device closure. We deal with these on a case-by-case basis and have been doing the Watchman device at the university. The Watchman device does require some period of anticoagulation while the surface of the device is endothelialized, because otherwise it would be actually a risk for the development of thrombus and stroke. Another important point while we're talking about stroke risk reduction is that the risk of spontaneous intracranial hemorrhage is highly correlated with blood pressure. One randomized trial of over 6,000 patients with a prior CVA and a mean baseline blood pressure of 147/86 found that reducing blood pressure by 9/4 millimeters of mercury decreased the annual rate of intracranial hemorrhage by half, from 2.4% per year to 1.2%. And it should be noted that uncontrolled hypertension is a relative contraindication to anticoagulation because of the risks of bleeding. So we should consider aggressive blood control in anticoagulated patients. Other strategies to reduce risk include close monitoring and lifestyle modification when using warfarin or other anticoagulants, the aggressive management of excessive anticoagulation with warfarin, the control of hypertension, instituting interventions to reduce the risk of falls. So at the university and specifically at Harborview, we have a falls clinic, which is run by one of our geriatricians and staffed by physical therapists who work with patients for strengthening balance and other interventions in the home to reduce patients' fall risks, avoiding NSAIDs if at all possible, the treatment of GI pathology, ulcers with H. pylori testing and therapy, and then close attention to patients with cognitive impairment, as we should always do with regard to their candidacy for anticoagulation and monitoring. So we have some take-home points, one of which is that, the first of which is that age is a potent risk factor for stroke both with and without atrial fibrillation. The diagnosis of atrial fibrillation presents an opportunity for us practitioners to practice shared decision-making. Antithromboembolic strategies need to be individualized. For some patients, that will mean anticoagulation with warfarin. For others, it will mean one of the novel anticoagulants. And for a few, it may mean one of the devices utilized that I described. It's important to discuss carefully patients' values and prior experiences, those of their family and friends. And in particular, talk about what you think their individual risk of stroke is, balanced with their risk for bleeding. Remembering that anticoagulation in general is underprescribed because of an underestimate of the benefits and an overestimate of the risk. And then lastly, it's important to remember that not all decisions are final and they should be re-examined. So a patient it may be best to bring up the issue at the time of diagnosis and then revisit it as It can take a lot for a patient to take in a new diagnosis of a heart condition. They may not be ready to discuss all the ins and outs of their therapy, while the more sort of urgent issues of rate control or rhythm control may take a front seat. Long-term anticoagulation may be something that needs to be addressed later or over time. I wanted to leave a lot of time for questions because I'm sure you have them. And so those are my prepared remarks.
Okay, I've asked the sites to get their questions ready, so hopefully some will be coming. Do we have any questions in the room while they're doing typing?
I have a couple.
Sorry, if you could repeat the question because it won't get picked up by the sites from her.
I worked at Harborview and I heard a lot of lectures from trauma surgeons about these new anticoagulants, and I wonder if also the perspective from a trauma surgeon that if you don't have an antidote for bleeding, I mean, what the risk of trauma for people in the elderly as with falls. It seems like it's a much less lower risk, but it scares people when you can't reverse it. You have to just wait. Do you have thoughts on that?
Yeah, so the question is, what about these novel anticoagulants in the setting of trauma or bleeding when there isn't an antidote? And it does concern me to a great degree, and that's why it's nice that that not only is there one available now, there's in development others, and some that are thought to be potentially more universally applicable. I think the difficult thing is that oftentimes a patient comes into the emergency department, they are unable to or don't know what medicines they're on, and all that the provider knows is that there's blood coming out, and so the INR is easily checked, comes back fast, but these other agents, you may not even know that they're on one of them. So I definitely have great concern about that. Hopefully in the future it'll be a little bit easier because there will be more available, and again, some of the ones that are in development are sort of more universally applicable. But I definitely think it's a concern.
But strategizing the risk, I mean, you can't strategize trauma because it's.
Yeah, so the further question is, I think it's sort of by definition unpredictable when it's going to be an accident. So it's always, it's nice when it's warfarin just because you know exactly what to do. The effects of FFP and of vitamin K are relatively predictable. So it just presents a challenge, yeah.
Missoula is wondering how often does the cost of the newer agents either enter into the choice of therapy?
So the question is, what about cost? And that's a great one.
They can hear me because I've got a mic.
Okay. So with regard to cost, it certainly can both enter into the choice of warfarin versus any of the novel anticoagulants, and then sometimes some insurances will only cover certain of the novel anticoagulants. It's becoming more and more common for those who have coverage for them to have access to at least one of them. Of course, patients who have no coverage, then they're relying on charity or another means. But in terms of patients that have some form of coverage, it's becoming more and more common that they have at least one of them that is covered. But it can be a challenge, particularly if you want to use one of them that isn't covered for a particular patient.
How do you approach anticoagulation in patients with isolated incidents of atrial fibrillation while they're sick, hospitalized, or critically ill?
Great. So that's a really excellent question. It takes into it brings up the issue of, is this isolated incident of atrial fibrillation? How isolated is it? So if a patient has multiple risk factors for atrial fibrillation, you do their workup, and they have other cardiac conditions, they have a valve disease, they have hypertension, diabetes, and so forth. You may err on continuing anticoagulation outside of this acute setting. Sometimes we'll perform surveillance rhythm monitoring, whether that's a 24-hour Holter monitor or a month-long looping recorder event monitor to try to surveillance for atrial fibrillation. But it's certainly true that sometimes it will just be episodic. It's just that atrial fibrillation is so common and with multiple risk factors, it makes you have to be very careful about deciding that it's gone forever.
So this is a question coming because, quote unquote, I'm just curious. A very good friend of mine was on an anticoagulant with a lot of other things going on. So he says, I'm kind of fishing for a reason here, but have you ever heard of any cases of severe chronic pain associated with anticoagulants?
I have not.
Okay. Port Angeles VA is asking, what is the diagnostic workup or time interval to start DOAC to confirm non-valvular fibrillation? What is the current consensus of valvular AF, MS, and artificial valve, not ASAI, mitral regurg, prolapse, that sort of thing?
Yeah, so that's a really good question. In general, so with an artificial valve, the novel anticoagulants are contraindicated. What constitutes valvular atrial fibrillation is essentially mitral stenosis as the contraindication in terms of native valve disease. The other valve diseases are generally not considered valvular when it comes to eligibility for the novel anticoagulants.
And I think this refers back to the question about the isolated incidents of AF. What about trying cardioversion at least once to fix the rhythm and the rate?
Yeah, so that's a common practice for a lot of people is to, they say like, let's give them one chance to maintain sinus rhythm, particularly in a setting where it's post-surgical, a patient's been monitored, you see that they've gone in it, they don't have any other reason to suspect that they're going to go back in it again. We'll often give them, quote, that one chance and try cardioversion once.
Okay, other questions here in the room? Okay, Seattle says, we understand that physical activity impacts INR even when dose of warfarin and diet remain consistent. Does physical activity impact INR with newer meds?
So I guess I'm not familiar with that that relationship per se, but I don't think that the efficacy of the novel anticoagulants are affected by physical activity per se.
Okay. Seattle is, we're getting lots of thank yous now.
Oh.
So I think you've answered